Okay, good morning, good afternoon, and good evening, everyone, wherever you are. My name is Rikke Kierkegaard. I'm the program specialist with the HIV and AIDS section at UNICEF headquarters in New York. And I'm very pleased to welcome you all to this third webinar we have in the webinar series from the Children and AIDS Learning Collaborative on what pediatric HIV programs need to know about COVID-19 and HIV. In today's session, we'll be providing scientific updates from the past month on COVID-19 in children, pregnant women, and HIV normative guidance and updates from the WHO, examples of PMTCT program adaptations, and then finally, we have a panel discussion with healthcare providers from South Africa, where they have just started opening up after their national lockdown. With us today, we have three presenters, Dr. Lynne Mofenson, Technical Advisor to the Research Program at EGPAF, Dr. Martina Penazzato, the Pediatric HIV Lead at WHO Headquarters, and then finally, Anne-Marjorie Mbule, Senior Program Lead at Mothers to Mothers. Afterwards, we have three panelists for our discussion. We have Professor Helena Rabi, pediatrician at Tygerberg Children's Hospital and Associate Professor of Pediatric at Stellenbosch University, Dr. Anita Prabhu, who is medical manager at Red Cross War Memorial Children's Hospital, and then Professor Mignon McCulloch, who is head of pediatric nephrology at Red Cross War Memorial Children's Hospital, as well as the chairperson of the South African Pediatric Association. We also have Luann Hatana with us to moderate this discussion, and she's the Executive Director of Pediatric Adolescent Treatment Africa, or PATA. So before we get started with the webinar, I'd like just to go through the housekeeping rules. First of all, if you have any technical issues, please send us a message via the chat box, and we will try to support as soon as possible. If you have any general comments, please also send them through the chat box, but please do select all panelists and attendees, otherwise everyone will not be able to see your comment. If you have any questions for any of the speakers, please send them at any time you wish using the Q&A box, which is located at the bottom of the Zoom window. You can send your questions in at any time during the presentations, but we will only be taking the questions at the end of the webinar during the Q&A period, which is after the panel discussion. This webinar is being recorded, and the recording and the PowerPoint will be made available online after the webinar on childrenandaids.org/COVID-19, where you will also be able to find many more resources from UNICEF as well as partners, and participate in discussions related to COVID and HIV in children and pregnant women. So I would now like to open this webinar with a presentation by Dr. Lynne Mofenson, who is working as technical advisor to the research program at the Elizabeth Glaser Pediatric AIDS Foundation. She was at the National Institutes of Health from 1989 until her retirement in 2014, where she was responsible for program planning and the development and scientific direction of research studies and clinical trials in domestic and international pediatric, adolescent, and maternal HIV infection. So without further ado, I will hand over the floor to you, Lynne.
Okay, can you hear me?
Yes.
Okay, good. So I'm going to provide a epidemiologic and scientific update on SARS-CoV-2 in children. So as always, I want to note that data still continue to be preliminary. Some are of poor quality, they change almost daily. And I do feel like that little girl down there, that there's a fire hose of information coming every day that makes it difficult to interpret the deluge of data that are coming in. So I first want to talk about an update of SARS-CoV-2 and HIV. This is a systematic review of COVID-19 and HIV, 17 studies in 146 co-infected adults from 9 countries, included 2 case reports from Africa, South Africa and Uganda. The pooled prevalence of HIV in SARS-CoV-2 cases was 1%, which was comparable to the 0.6 to 0.8 prevalence in the general population. Excuse my voice here. 65% had at least one comorbidity, most commonly hypertension, hyperlipidemia, and then diabetes, hepatitis, and chronic respiratory disease. And the symptoms overall were similar to the population at general: fever, cough, dyspnea, diarrhea, and an abnormal chest X-ray in a little over a half. Disease severity was mild in 56%, moderate 16%, severe in 24%, which is a little higher than the general population, and critical in 4%. This shows you the, excuse me, pooled mortality among co-infection cases from 6 studies. One second. There we go. The pooled mortality in co-infection cases was 9%, ranging from 3 to 15%. And this is not dissimilar from the general population, where it's 5.6%, ranging from 2.5 to 12.5%, so kind of in the middle. These are data comparing COVID-19 in HIV positive and HIV negative adults. They used electronic medical record data for hospitalized patients admitted to NYU Hospital between March 2nd and April 23rd. And they matched 21 HIV infected individuals with 42 non-infected individuals who had COVID-19 by the criteria that you can see on the slide. All of the HIV patients were on treatment, and the majority, 15 of 17 who had a test, had an RNA less than 50. So more HIV patients had consolidation on chest X-ray, 91% versus 64%, and there was a non-statistically significant higher proportion of HIV patients who required ICU care, mechanical ventilation, or died or required hospice compared to the non-HIV cohort, but as I noted, this was not statistically significant. And the authors concluded that overall findings suggested that HIV status did not significantly impact clinical outcomes. These are really excellent data from Marianne Davies in South Africa, presented on a public webinar a couple of days ago. She used Western Cape routine public sector data that has unique identifiers to look at factors for risk of COVID-19 deaths in 342 adults over 20 with confirmed COVID-19 who had died, and basically address the question, how much more likely are you to die from COVID-19 if you have versus don't have a risk factor? So on the left, you see a table with the different characteristics that were evaluated and the adjusted hazard ratio and confidence interval. And on the right, you see it pictorially, which I think is easier to see. And you can see males were more likely than females to die, and older individuals over 40, and particularly those over 60 or 70, were more likely to die. Those with non-communicable diseases, in particular uncontrolled diabetes, hypertension and chronic kidney disease, and TB and HIV, current TB. There was no difference in the risk, however, by viral suppression in those who were HIV positive. So these are the first real data looking at HIV and COVID. So she found that older age and comorbidities increased the risk of COVID-19 death, particularly uncontrolled diabetes, hypertension, and renal disease, and that the increased risk of COVID with HIV or TB is a modest 2 to 2.5 increase compared to those without HIV or TB, and noted that this may be an overestimate as they haven't fully disentangled all relevant comorbidities and risk. The effect of HIV or TB was smaller than the effect of other comorbidities, and also those with HIV or TB tended to be younger, where the overall risk of COVID-19 death is lower. And overall, less than 10% of COVID-19 deaths were viewed as attributable to HIV. There are, however, no data on children or adolescents with HIV and SARS-CoV-2 to date. So to talk briefly about treatment, starting with chloroquine and hydroxychloroquine. So we have the studies up here that show it doesn't work in animal models, doesn't work with severe disease, doesn't work with mild disease, doesn't work as post-exposure prophylaxis. and adverse cardiac effects have been observed. And so NIH has halted the hydroxychloroquine study, FDA has withdrawn emergency use authorization, and WHO ended their hydroxychloroquine arm. So nope, this is not going to work. However, we do have good news with remdesivir. It's a nucleotide analog given intravenously that has shown moderate efficacy in randomized trials. In animal models, although viral shedding in the upper respiratory tract wasn't reduced, the viral load in the lung was significantly lowered with a significant reduction in damage to the lung, and they concluded that remdesivir initiated early during infection had a clinical benefit. A compassionate use study in individuals with severe and critical illness showed clinical improvement in 68% with treatment, but there was not a control group. A randomized, controlled, placebo-controlled clinical trial in patients with severe disease hospitalized with pneumonia found that remdesivir was superior to placebo in shortening time to recovery, 11 versus 15 days, with a trend towards reduced mortality, 21 versus 27%. And then finally, Gilead has done a study that compared 5 days of intravenous versus 10 days of intravenous remdesivir in patients with severe disease, and basically showed that it looked like the 5-day course was as good as the 10-day course. We also know that it's safe for use in pregnancy. There's been a publication about compassionate use in pregnant women in the US. Gilead is about to begin a clinical trial in children. And they're talking about a new formulation inhaled via a nebulizer, which they're planned to put under study. And finally, dexamethasone. The recovery trial in the United Kingdom is a large randomized trial looking at a number of different treatments for hospitalized patients. They have over 11,000 participants, and they're randomized to hydroxychloroquine, which has been stopped, low-dose dexamethasone, lopinavir, ritonavir, azithromycin, and the others as you see here. And they recently stopped the dexamethasone arm for efficacy, including survival, which I'll show you. They are enrolling children, and that is continuing. So if you look at these graphs, dexamethasone is shown in red, and standard of care is shown in black. There was a 17% reduction in mortality for all participants, 20% reduction in mortality for those requiring oxygen, and a 35% reduction in mortality in those who required ventilation. However, in those who did not require oxygen, who were doing really well, there was no reduction in mortality. And based on this, the Infectious Disease Society updated their guidelines just a few days ago, 4 days ago, to recommend the use of dexamethasone in people with severe COVID-19 and to recommend not using dexamethasone in people who are doing relatively well. So what are children with COVID-19 being treated with? And these are data from a weekly survey of 87 participating pediatric ICUs in 21 countries that is being conducted by the University of Texas. And you can see the countries on the right. And this shows you the answer to the question, what medications does your site use or plan to use in patients with severe disease, so people who are intubated? So 50%, more than 50% use anticoagulation prophylaxis, primarily low molecular weight heparin or aspirin. More than 50% are using remdesivir with compassionate use, and more than 20% are using intravenous steroids with a number of other treatments, including IVIG in a smaller percentage. So to move to talk about demographics and epidemiology. So COVID-19 incidence in children remains low, but there is significant variation. And these are data from country online databases, and they show a broad range of COVID-19 burden in those under 20, ranging from 1% in Spain to 23% in Paraguay. It's higher in low and middle income countries, more children there compared to high income countries, 11 versus 7%. and just wanted to bring attention to the studies in the reports from Africa, South Africa, Nigeria, Kenya, and Brazil, where the epidemic is just accelerating, and there appears to be more children there. Now, there may be differing policies in countries related to who gets tested, and if children are less likely to be tested because severe disease is required, then the prevalence is going to be low. But accurate age disaggregated data are going to be critical to better understand these geographic variations in age distribution in children. There's a global lack of age disaggregated data, and it's difficult to determine the proportional age breakdown within the age 0 to 19 years. They're limited, reports use different age categories, and what I've shown here are national data on lab-confirmed cases from the US and China that have been published. So this is 3,303 children, and you can see that cases are diagnosed across all age categories, from neonates to adolescents, with adolescents greater than 10 accounting for 55% of those with COVID-19. So I want to talk a little bit about race and ethnicity. In the US and the United Kingdom, COVID-19 is more common among Black and ethnic minority adults, but if you go into the literature on children, there are limited data, and most pediatric studies don't report on race ethnicity. But studies from Chicago, Texas, New York City, and the United Kingdom suggest a similar disproportion for race and ethnicity in children as observed in adults. And this is just an example. In Chicago, they tested 474 children. Of these, 25 or 5.3% were positive, and the positivity rate was 6.8% for Black, 6.6% for Hispanics, versus 1.7% for white children. And on logistic regression, Black race and older age were risk factors for positivity. Now, this racial disparity may reflect a number of different things. It may reflect socioeconomic and demographic factors that increase exposure risk, a higher prevalence of chronic comorbidities in minority populations. This applies probably more to adults, or undefined biologic factors. But this disproportionate representation is concerning given the extension of the pandemic from high income to low and middle income countries. And at a minimum, studies in children and adults should be reporting on race, ethnicity, and further studies are needed to evaluate the reasons for this disparity. But I thought I would show you this. This shows the importance of socio-demographic factors. This is a cross-sectional evaluation of 434 pregnant women in New York City who delivered at 2 New York City hospitals that were doing universal screening. Of these women, 71 or 18% tested positive. So they looked at all of those who were tested and linked that to socioeconomic and demographic data to look at what the probability of infection was associated with. And neighborhood median income. The lower the neighborhood median income, the more likely you were to be positive. Neighborhood unemployment rate. The more unemployment, the more likely you were to be positive. Number of residents per unit. The more residents, the more likely you were positive. And having more than 1 resident per room, again, more likely to be positive. So clearly these factors play an important role. So moving on to talk about clinical manifestations. These are data from Children's Hospital of Philadelphia that has a large ambulatory care network with over 1 million patients per year. And they extracted electronic medical records for over 7,000 children and youth with a valid test result for the 2-month period shown here. And this shows you can you still hear me? My internet connection, yes?
Yes.
Okay, good, thank you. So this looks at the daily testing in the network, and the gray shows you negative tests and the black shows you positive tests. 39% of the testing came from drive-through sites and 32% from the ER. 5.8%, 424 were positive. Of these, 54 or 13% had no symptoms, and 57% of those who were positive had comorbidities, most commonly asthma, obesity, mental health issues, and neurologic disease. And you can see that they were doing symptom-based screening before March 24th, and after April 1st, they were doing universal screening. So focusing on the 424 children who were infected and looking at characteristics, first you can see comparing infected children to the general population tested. The infected children were older with the median age of 10 years versus 5.9 years, with the highest positivity actually being in those aged 18 to 21, followed by 12 to 17. As the studies I showed you before, African American children were more likely to test positive. Children who were screened due to symptoms or known exposure were more likely to test positive, 21%, and 3.8% of children undergoing universal screening were positive. So looking at the illness in these children, 77 or 18% of the 424 infected required hospitalization. 25 of these, or 33%, required intensive care. 16% required mechanical ventilation, 2 of whom required ECMO. 17% required vasopressor support. Anti-SARS therapy was given to 12%. Steroids were given to 20%. They had 8 children with multi-system inflammatory syndrome, which we'll talk about. All received IVIG. And finally, 2 of 77, or 3%, died, which is 0.5% of all positives. This looks at mortality by age group in the US, and there is a low mortality in children, but it may actually be highest in youngest children. The overall mortality for those aged 0 to 17 was 1.8%, but 1.7% of that was in the youngest children. And you can see that young adults also had very low mortality. So while mortality in children may be rare, it can occur, and it is particularly high among children who require admission to pediatric ICUs. And here are 2 studies, one from the US and Canada with 48 PICU admissions, 2 deaths, 4%. But in addition, 3 are still on a ventilator and 1 on ECMO at the time of the paper, so that's 12.5%. And then in France, 27 admissions, 5 deaths, 18%. And there were a high rate of underlying conditions in children admitted to PICUs. And I wanted to bring to your attention medically complex, which really means developmental delay, genetic disorders that are more neurologic, seizures and neurologic conditions being highly prevalent. Sickle cell disease comes out as a comorbidity, and obesity. However, of the 7 deaths, 3, or 43%, had no underlying comorbidity. I want to talk a little bit about underlying medical conditions in COVID-19. So while asthma is one of the most common comorbidities reported in infected children, it actually does not appear to predispose children to infection or increase hospitalization risk in those who are infected. And there's an interesting study that shows the ACE2 gene expression is lower in those who have asthma. Cancer, there was a universal screening at Memorial Sloan Kettering in New York City, a cancer hospital. They screened 178 children, found 11% infected, only 5% required hospitalization, so it doesn't appear to be more severe. We have no data on SARS-CoV-2 in malnourished patients, but we do know that it appears to be associated with increased morbidity and mortality in both children and adults with obesity. Brief update on multi-system inflammatory syndrome that appears temporally associated with COVID-19, which can cause death, as you can see in this news report. Just to remind you, this is children who present with persistent fever, laboratory signs of inflammation, and evidence of single or multi-organ dysfunction, including shock, cardiac, respiratory, renal, GI, dermatologic, and/or neurologic symptoms, and they may meet the full or partial criteria for Kawasaki's disease. And the figure up there on the right shows you in red the Kawasaki's disease type symptoms. And SARS-CoV-2 RT-PCR testing may be positive or may be negative, but also often you see SARS-CoV-2 antibody positivity or a history of a recent positive contact. So as of June 23rd, there are 36 published reports, including over 500 children from the US, Italy, United Kingdom, France, and more recently, South America, India, and Pakistan. And this shows you 4 of those studies. IVIG treatment is the most common treatment. While mortality was relatively low, you can see that severity was high with 4 at least requiring ECMO. And cardiac aneurysms were noted in a number of these children. And because of the frequent myocardial dysfunction and potentially for coronary artery aneurysms, continued follow-up, particularly with cardiac echoes of these children, are needed following recovery to evaluate long-term effects. And this shows you the kind of treatments given. This was a survey done by Mike Levin at the Imperial College in London, and he's doing a study called Best Available Treatment Studies, or BATS, because we're unlikely to have data from randomized trials. And in a survey of cardiac centers, over 1,000 children have already been treated with IVIG being most common, steroids, aspirin, anticoagulants, anti-IL-1, anti-TNF, but they don't know what works. And additionally, many countries have a shortage or lack availability of IVIG or biologics like anti-IL-1. So hopefully steroids will turn out to be the best bet. So they're using data on already treated newly presenting children, comparing response defined by inflammatory markers and outcomes as shown on the slide by what treatment they're receiving. And it's an international site. They already have 60 sites in 24 countries. You can enroll your patients from any site. There are no individual patient identifiers, and I've put the website on the slide. And this is for you later when you access these slides, just to let you know, WHO has a global COVID-19 clinical platform and reporting system for multisystem inflammatory disease, and the websites are shown here, and there is a nice scientific brief summarizing this. So talking now about susceptibility, these are data from a systematic review that looked at contact tracing studies, so looking for secondary infection of an initial infected individual, and population prevalence studies, both virologic or serologic testing, identified 18 studies, 9 contact tracing, 6 and 8 population screening, and the majority were from China, but you can see a number of other countries were involved. So this looks at the 8 household contact tracing studies. And preliminary data here suggest a lower odds of infection in children compared to adults. So child contacts under age 18 to 20 had a 56% lower odds of becoming infected after contact with an infected individual than adult contacts. Little difference when they included better quality studies only that had lower issues of bias, but they had insufficient data to explore whether there were differences between the youngest children and adolescents. These are the 8 population-based surveillance studies. Data here were more heterogeneous, not suitable for meta-analysis, and had mixed results. So 2 viral detection studies and 2 national seroprevalence studies showed a lower prevalence in children than adults. However, 2 viral detection studies and 2 seroprevalence studies showed that the prevalence of infection was similar in children and adults. And so there's a significant uncertainty here and issues with the surveys, but doesn't answer the question. And before I talk about susceptibility, I just want to point out that we now know that there's a little bit of a difference in terms of how the virus enters. There are 2 cellular proteins involved. the angiotensin converting enzyme 2, ACE2, and a type 2 transmembrane serine protease, TMPRSS2. And that expression increases cellular uptake. So the spike protein binds to the ACE2, the cellular protease binds to the ACE2 and it cleaves it, and it also cleaves the spike protein, which activates it and primes it for cell entry. And the cleaved ACE2 and the activated spine protein together enable cell fusion. So we've already seen some of this data. This was an examination of stored nasal epithelium that was looking at markers of asthma, and they evaluated ACE2 gene expression in stored samples. And ACE2 gene expression was age dependent, being lowest in children under 2, and significantly lower than adolescents aged 10 to 17, young adults aged 18 to 24, as well as those over 25. And this is a newer study that used public expression data sets, and they also looked at TMPRSS2. And they found that children, which are the black bars here, had significantly lower expression, not just of ACE2, but also TMPRSS2 in the upper and lower airways. And also they found that the expression of these factors were significantly upregulated in patients with COPD and smokers, both of which is associated with more severe disease. So what about transmission from children to others? So the role that children and young people play in transmission depends on multiple factors. The risk of exposure to infected individuals, and right now children are less likely to be exposed because we've got all these mitigation interventions in place. The probability of being infected upon exposure, and we talked about that children, particularly young children, may have lower susceptibility. The extent to which symptom develops, and children are more likely asymptomatic. Propensity to make potential contact with others in school reopenings will increase this. And the extent to which viral load is sufficiently high to transmit. And there are mixed data on viral load in children and adults, but I wanted to look at one study that compared viral load and immune response in 37 asymptomatic adults that were infected to 37 matched mildly symptomatic adults. And they found no significant difference in nasopharyngeal swab cycle threshold, which is a surrogate for viral load, between asymptomatic individuals in green and symptomatic individuals in pink. They actually found viral shedding was longer in the asymptomatic individuals than symptomatic individuals, and found that virus-specific IgM and IgG levels were actually lower in the asymptomatic than the symptomatic persons. And in the convalescent phase, 40% of asymptomatic, 13% of symptomatic persons became IgG negative. So the issue of susceptibility and transmission is particularly important relating to school closings and reopenings. And this map just shows you as of yesterday closure status. You can see most states in the US have schools closed for the remainder of the academic year. So what about COVID-19 investigations in schools? These are data from New South Wales and Australia that did a contact investigation after they had 9 students and 9 staff have COVID-19 diagnosed. There were 735 students, 128 staff used as close contacts, 288 had either RT-PCR or blood samples taken. So of those evaluated, only 1.3% of the students had a positive PCR test, and only 1 of 96 students with a negative PCR had a positive antibody. So overall, the rate of infection was only 0.3% in students and none of the staff. So this suggests a low infection transmissibility. These are data from Norway on reopening of primary schools during the pandemic. In Norway, as globally, the proportion of children with COVID-19 is low. 7% of cases have been in children. The graph shows you the number of confirmed cases in children 6 to 13 in that mustard color, and then either under 5 or adult age in the blue. 0.9% of the cases have been in preschool children, 2% in primary school age children, 4.2% in kids 14 to 19. So here you see when they implemented national control, including school closures. And here you see opening of daycare centers, opening of primary schools, and you can see that there was not a big increase in the rate of infections overall. So no increase in infections in this 4-week period. Now maybe that's too short, but again, suggests that children are not so contagious. And again, this is put here really for you to look at later, which is Norway guidelines for reopening and the kind of physical distancing and precautions that they put in place as they opened the schools. But we're in the midst of a grand experiment. And as you can see from these headlines, there has been a number of cases where schools have reopened in France, South Korea, and in Israel, where they then found cases in the schools and had to reclose. So we really don't know what's going to happen yet. And I wanted to point out that this lower susceptibility to infection may only apply to young children and not to adolescents. And these are data from a recent MMWR where they investigated 3 University of Texas students who were diagnosed with COVID-19 after they returned from a spring break in Mexico, in which 231 other spring break youth or contacts were tested. 64 or 28% had positive RT-PCR test results, including 1/3 of co-travelers, and about 1/5 of the children of the people who were infected were asymptomatic when tested. And we're seeing a changing epidemiology to a younger age group. This is from Germany, and they looked at the relative risks for being a COVID-19 case in the early time period, 10 to 11 weeks, compared to a later time period, 13 to 14 weeks. And you can see in the red box that there was a significant increase in the number of cases in the later age group, in those 15 to 34, and in the blue box, particularly those 20 to 24. So there's a growing role of adolescents and young adults. While they might have minor illness, they may be at highest risk for contracting and spreading infection. And this has been seen in the US at all. These are data from Washington State, looking at confirmed cases by age to look at what happened over time from March to May. So over this 9-week period, in the yellow, you can see there was an increase in cases in children aged 0 to 19 years from 1% to 11%, an large increase in red in cases 20 to 39 years from 19 to 39%, not much change in those 40 to 59, but a decline in cases in those who are older. So we're seeing an evolution to younger people being infected. So in conclusion, children continue to represent a low proportion of cases, but there are disparities between countries, issues of race, ethnicity, and these need to be explored with global and country-specific age disadvantage, particularly obesity, neurologic disease, sickle cell appear to have more severe disease or mortality. There's continuing evidence of the multisystem inflammatory syndrome, which continues to show us that we still have to define better what disease is due to SARS-CoV-2 in children and youth. And we clearly need better data on susceptibility of children to infection and transmission and the lack of role or potential role of schools in the pandemic. And finally, adolescents and young adults represent an emerging proportion of infections as the pandemic evolves and may represent an asymptomatic reservoir of spread. And thank you for your attention. And I will stop screen sharing there.
Thank you, Lynn, as always, for really an excellent overview and very broad. And I think the data from South Africa, as well as the data on school reopening, disaggregated by race and child mobilities, really give us valuable information to set the stage for our panel discussion with South African healthcare providers later on. So I will now move on to more normative updates from WHO and introduce our next speaker. Dr. Martina Penazzato is a pediatric HIV lead for the HIV, hepatitis, and STI program at the WHO headquarters in Geneva. She's an infectious disease specialist and has spent more than 15 years contributing to clinical research and developing global policies on pediatric HIV. Prior to joining WHO, she developed her research interest in Uganda, and for the past 6 years, she has led the work of WHO on pediatric treatment and care, where she has contributed to a number of global initiatives to improve access to HIV services and to improve pediatric ARV formulations for children living with HIV. So Martina, I'll hand over to you.
Thank you very much, Rika, and thank you to UNICEF colleagues for the opportunity to really contribute to this webinar series, which I find extremely helpful. It's never easy to follow Dr. Mofenson and her comprehensive presentation, but the goal of my brief presentation today is really to just give you some pointers to some of the WHO work that I think you may find useful, and that I think that as you know, other colleagues in WHO are leading and coordinating, particularly within the emergency unit, as well as part of the maternal and child health work that is more broadly happening in WHO. So I just want to remind you that, of course, you've heard a lot about what WHO is doing in the COVID pandemic response, but I think the three key high-level aspects that have been really the core of our work, it's been around slowing and stopping transmission of COVID-19, minimizing the impact of the epidemic on the health system, and really providing guidance and support to how to optimize care for all COVID-19 patients and really reduce mortality. And we know that that means developing evidence-based guidelines on clinical management for COVID-19, and this is something that we've done from the very beginning with and updated our clinical management recommendations twice since the beginning of the pandemic. Really acknowledging the evolving set of evidence that Dr. Mofenson has taken you through, and ensuring that that's captured in our guidelines as much as possible. We also know that these come to a proactive effort, in generating and gathering more information on the disease presentation and outcomes, particularly in some subpopulation, and this is something that is obviously very, very relevant to us that work largely in maternal and child health and in HIV, for example, and we know that's always a challenge. I want to just remind you first of our normative guidelines in terms of clinical management for people with COVID-19, and this is a document that was launched on the 27th of May that really contains our current recommendation in terms of clinical management. And you can see here the table of content, just to reflect on the fact that this new iteration of the guidelines has really expanded its scope to include consideration around screening and triage, IPC measures, as well as laboratory diagnosis, and obviously to reflect on a number of key consideration and recommendation on the management of COVID-19 patients in their several and different clinical presentations. There's also a number of specific consideration for subpopulation, and clearly the clinical presentation in children is recognized within this clinical management, and you can see it throughout the document, and there are specific recommendations for managing pediatric patients, but there is an overall acknowledgement of the epidemiology and disease presentation that Dr. Mofenson has illustrated earlier. So cases being less frequent and having a milder presentation, with also some specific features that are not necessarily being seen in adults yet, like the multi-system inflammatory syndrome. This document also reflects better some of the therapeutics that have been considered in a number of clinical trials so far. And obviously, things are happening quite quickly these days. So I know that our colleagues in WHO are really considering how to capture the evidence that Dr. Mofenson has referred to with regards to the efficacy of some of these therapeutic options in COVID-19 patients. One thing I wanted to note is that, as many of you know, children are rarely included in some of these trials. The recovery trial is the one that has included children from the beginning, and I believe it's counting now 15 to 20 pediatric patients at the moment. So we know, as Dr. Mofenson said, that we are unlikely to generate a lot of direct evidence in children in the immediate future, and we are likely going to find ourselves in a situation where we'll have to extrapolate what we see in adults. And in light of that, one of the efforts we've had in WHO has been to scan the potential gaps that there are in terms of approval or dosing of some of these therapeutics in children. We're lucky that some of them had already been used and were established products that were being used in children, but others aren't. And you know that the remdesivir pediatric investigation plan has been approved in a very rapidly as a simple study that it actually following a lot of the key standard practice that we are promoting from WHO. So we hope that that will enroll quickly and really produce the evidence that we need to expand access to these potential therapeutic in children as well where needed. We've also seen that some of the monoclonals, for example, do have potential indication from 2 years of age, and we'll keep an eye on those that are more promising to really see whether there is any gap that needs to be filled in the future. So this is clearly a piece of work that we are keeping a close eye on. These guidelines also include consideration in the care for pregnant women, and specifically consideration around how to support breastfeeding. And since the release of these guidelines, actually, there is a new document that was released last week, which is a scientific brief, which had the goal to really summarize what's our position with regards to breastfeeding and consider the most recent evidence that has been generated, and as you know, fairly limited, and reflecting on the fact that obviously the risk of transmission of COVID-19 needs to be put in the context of the value and important benefit of breastfeeding for children. And I think that this scientific brief emphasize our current position, which is to recommend initiation and continued breastfeeding of infants and young children, also in the case of suspected or confirmed COVID-19 cases. So really important to emphasize this point at the country level. One element I mentioned earlier is our efforts in trying to generate data, and Dr. Mofenson has given a great overview in terms of what's publicly available, but obviously this pandemic requires us to anticipate publications and wherever possible trying to pull more information all around the world. And this is something that we are very actively working on through what we call the WHO Global COVID-19 Clinical Platform, which is a system that enables a rapid, standardized and systematic collection of anonymized clinical data and of patients that are hospitalized because of COVID-19 in all settings and all subpopulations. And the goal of this work is really to facilitate aggregation and ensure that there is a more standardized approach to the way we look at this data. But as we all know, the importance of this is particularly important for the pediatric population, where the limited number of cases compared to the one on adults may limit our ability to extract and interpret the data that we see. And so gathering will allow us to have more stronger interpretation of those findings. This platform, it's secure, has a limited access, and so really is password protected and is managed by WHO on the web. I wanted to just point you to some of the practical aspects of this platform. There are 3 case record forms. One is a general one that is used for patients with COVID-19, irrespective of their age. So these would include children. And there is a dedicated CRF for pregnancy that collects important information for the mother. And then there's been a new CRF that was designed as soon as we started to have reports on the multi-system inflammatory syndrome, with the idea of really characterizing better this syndrome and gathering data more quickly. All of these forms have typically a module which is recording data at admission, and then following up and then assessing outcomes at discharge, that transfer. And so these data, it's a mix of prospectively recorded as well as retrospectively recorded. And the way, and one of the important features of these CRFs is that there is a number of information regarding comorbidities that will be critical for the HIV community, for example, to be able to compare different outcomes depending on whether individuals are HIV, people living with HIV or not. And so we really hope that more and more data will come our way through this platform to be able to analyze this data further. There's two key ways of contributing this platform, either directly through the CRF and a website that I'll leave that there for you to use, or if you were already collecting that data at your hospital in your country and you had a database available with most of this information already recorded, then WHO would work with you to really ensure that that data is transferred automatically to our platform without any extra steps. So that's something quite handy. So I'm just leaving you here the context of the colleagues in WHO that manage this. And then just to note that obviously WHO will use this data to summarize some of the characteristics, analyze them, and share them in a public report. And it's important to note that obviously the contribution will be acknowledged, but also that this will by no means prevent anyone to publish or share their data in the public domain. And this is all being really noted from the very beginning. And so we really invite those of you that are sitting in the Ministry of Health in specific health facilities or are part of clinical research networks to really join this effort and help us to get as much data as we can, particularly, as I mentioned, for children where there is limited information, and being able to gather them in one place will make our analysis much stronger in many ways. These are some of the links that I'll leave there for you to consult. And I just wanted to close by referring to a document that we put quite a bit of effort on, and that really reflects the contribution of several departments in WHO, which is really geared to promote continuation of essential health services. And this document is quite comprehensive. It's really meant to cover most of the essential services that countries are implementing. But I want to flag two components of this document in particular for the audience that is listening to us today. One section that really relates to the care of children, in particular and adolescents, which is where you see a number of considerations that are summarized in this table on the slide, and that, for example, highlight the importance that when dealing with sick children are followed up with chronic care, we should try to limit the frequency of face-to-face visits and ensure that medications are provided with longer supplies, and that really we should try to use digital solutions to communicate with patients and caregiver as much as possible. Obviously, the standard practice in terms of providing more acute care and immunization are also included in this document. And I want to note there is a specific mention around the integration of SRH and HIV services for adolescents that you can also see here. The other section I wanna flag is the one related to HIV treatment and monitoring, and apologies for the quality of the image here. But I think that it's clear that what we are hearing is that there are a number of disruptions in countries, and we are having periodic calls with our country officers as well as some of the partners are on the ground to really have a better sense of the level of disruptions that is being reported. And I think that ongoing work is really there to assess the actual degree of these disruptions. But as we think about HIV programs and how to ensure that HIV services are delivered to patients, particularly to children and adolescents that we know are a vulnerable population in this context, it's critical that we think about our HIV services in a slightly different way. And I just want to note with regards to ART for children that there is a clear, specific mention here of the importance of prioritizing, as usual, optimal regimens containing lopinavir, ritonavir, or dolutegravir. Again, this has always been important since the time when we changed guidelines, but this is becoming more important because in times where some disruptions may also affect stocks and adherence, then having more potent regimen may prevent selection of resistance further on. We're also encouraging the use of multi-month dispensing in children and adolescents, which we know is something hasn't really happened enough everywhere. And so we know that this has been uptaken more, even though sometimes the stockouts are really making it difficult to happen. But certainly it's something that we encourage and promote. And then the use of, follow-up through SMS text and phone to ensure that there is a continued interaction with patients where possible. I think that we all working together to try to see how we can be of assistance to programs in the near future, and certainly with UNICEF as well as other partners and stakeholders, we are trying to understand what are the tools that we can develop to ensure that perhaps we do some catch up once our patient will be able to come back to the facility, and how we should think about maybe doing more frequent, provide some of the service that we already know, but provide them more frequently or in an intensified manner so that we can better address the needs of these population at a difficult time like this one. So we're continuing to monitoring the situation, and really obviously keen to address and adjust some of our documents as we learn more. But this is where we are at the moment, and I'm very happy to address any question that people might have later. So thank you very much for the opportunity again.
Thank you so much, Martina, for this excellent guidance overview. And I think with this, we can move on to see a little bit about what is happening in practice. Today's programmatic speaker is Marjorie Mbule, the Global Senior Program Lead at Mothers to Mothers. She has 14 years of experience in program design, management, implementation, quality improvement, and monitoring and evaluation of integrated programs in the areas of HIV prevention, care, and treatment, PMTCT, reproductive, maternal, newborn, and child health, nutrition, and WASH. Marjorie leads Mothers to Mothers reproductive, maternal, newborn, and child health, as well as the prevention, care, and treatment portfolio. So Marjorie, the floor is yours, and I will just upload your presentation. Please go ahead, Marjorie.
Thank you so much. And it's very exciting to be part of this webinar and also representing programs. Overall, we have heard from science, but now we need to know what is going on in the field. It is very good for us it is exciting for Mothers to Mothers to be sharing our experiences, which are representing 10 of our implementing countries in sub-Saharan Africa. These are basically unprecedented times that we are finding ourselves as people who work in programs across countries, in which we have seen and been required to accelerate the need to develop scalable and technological community health worker solutions, both to support primary health care, universal health care during the times of national emergency. As Mothers to Mothers, we are committed to continuing to provide life-saving services to our clients using technology, but most importantly also hand in hand while protecting our field staff and clients. Next slide, please. So under lockdowns in our various countries of implementation, we continue face-to-face peer services, but with modifications as per country and WHO guidelines, respecting social distancing, large group gatherings, and others. We developed a phone-based client-centered service that provides interactive intervention to continue to provide quality peer support to our clients, using mothers to mothers existing digital mobile health tools, which are actually based on any Android smartphone. We provide all existing M2M clients, and what we did was to develop risk matrices that align to their disease profile. At the most basic level, our country teams classify the client as high risk or low risk based on either whether they're in a discordant relationship or whether they're PMTCT mom who has is newly diagnosed for HIV or is virally unsuppressed treatment. M2M field staff are trained to provide these services to each client according to their risk profile. And we actually managed to come up with a particular dosage, which I'll share as a lesson learned later, around how many phone calls would be enough, or is it enough, or is it too much? We are quickly developing a virtual mentor mother platform. Currently, we have 2 WhatsApp lines, one that is dedicated to our clients, and the other dedicated to our frontline workers, because we found that it's very important to keep in touch with supporting the quality of work that they do. And irrespective of this, every virtual mentor mother platform work that we do on WhatsApp is a sign up link, and therefore clients sign up to these respective services. So here I do have a few minutes, so I just try to go straight into sharing a sneak peek into our initial results. From the slide that I'm showing, although we have managed to contact only 46% of our clients, because a number of them in especially Eastern Africa like Malawi and Uganda don't have phones, we have had a very successful encounter here with us reaching for 94% of the clients, and out of those that we reached, 98% consented to receiving regular adherence and retention in care support on phone. And for the 4 months we've implemented now, we can see a success rate of 100%. Next slide. In countries where we had, where transportation is hugely affected among both healthcare providers and clients, M2M also devised strategies of working with healthcare workers and other clinical partners to make sure that PMTCT clients remain in care. In some of our countries like Uganda, the case study that I'm highlighting on the graph is a Uganda case where transport restrictions were significant, and mothers to mothers continued to play a role in distributing pre-packed ARTs to clients. These were pregnant women at risk of dropping out of care in East Central Uganda where we work. And we see that out of 79% of those clients who missed their appointments because they couldn't travel to their facility, we reached 90% of those, which is 229 women with ART, their pre-packed ART refills delivered at their homes or in the communities by the mentor mothers. This next slide is the last data slide that I have that shows us a sneak peek into ART pickup for us to be able to understand whether our interventions within the COVID-19 pandemic are yielding results. We implemented and continue to implement our quality assurance, quality improvement initiative, which we call Bring It On. And under Bring It On, we try to monitor appointments that are due and those that are done. And we have realized that across the 4 months, with the lockdown being mainly in March, the PMTCT clients picking up their ART that was according to schedule remain consistent. It's not 90%, but at least we see that they actually, a number of them managed to get their treatment either through follow-up by a mentor mother or delivery of the ARTs at home. So what does planning for reopening look like with mothers to mothers reflections? One, as the economy is slowly open across countries, mothers to mothers have started implementing a hybrid model, and we're sharing that at the center of all this, we need to put the client first. Although some clients are becoming more comfortable with home-based follow-up, we see that clients in urban areas are very encouraged by the peer via phone services. And among those clients, M2M aims at sustaining phone-based service delivery. So with a hybrid model, we are beginning to support our 10-country programs to look at whether a client will receive a face-to-face service plus a peer via phone calls, plus maybe household interaction. This will depend on the risk of the client. We also note, however, that with multi-month distribution of ARTs, early infant diagnosis and final infant tests remains challenged. And I think one thing that we have learned is that collaborations with clinical partners during this time to take early infant diagnosis and infant testing closer to their communities is going to be very important while mothers receive multi-month dispensing or distribution. I don't know how many more minutes I have, but maybe I can just skim through quickly. The other slide is about a lesson learned that soft skills are important. We have found moms who say, please call me when my partner is away, or don't call me during working hours. So irrespective of what it is, while we continue to provide services during the COVID-19 pandemic, and as we reopen, confidentiality matters. And if a mom says, I'm still not comfortable with you providing me services or coming to the health facility, we need to bring the services to the clients. My second last slide is really to share that as essential services work for, as our mentor mothers are essential, are considered essential at the respective health facilities that they work, we need to also make sure and understand that they also have a psychological burden. This might place on our staff, and supporting mental health of our mentor mothers remains an absolute must. And because of that, we as mothers to mothers have put together an international clinical oversight team that regularly reviews a site assessment form that allows us to monitor the health of our mentor mothers and their viral load suppression rates, their CD4 count, and make sure that we remove them from the front line in case it's necessary, provide them with enhanced adherence counseling so that they can be able to provide health while they are healthy. Thank you.
Thanks to you, Marjorie. This was a really interesting overview of the programmatic adaptations that M2M is implementing in country. We're now moving on to the last part of today's webinar, which is a panel discussion with South African healthcare providers. And as always in this COVID context, there's so much information and so much to say that we're running a little bit behind. So our presenters will continue answering questions in writing in the Q&A box, but most of the rest of this webinar will be focused on this panel discussion. So I would like to hand over the floor or the screen to Luan Hatane, who is Executive Director of PATA's Action Network of Frontline Providers, and she will be introducing our panelists and moderating the discussion. Please go ahead, Luan.
Yeah. Thanks so much, Rika. Thank you. I'm going to try and put my video on as well. I'm not sure if that's working. Yes, there we go. Thank you so much, and thanks to all the earlier presenters as well. For the next 20 minutes or so, I'm going to be posing some questions at our three panelists, all of whom are from Cape Town, South Africa. And as we all know right now, South Africa is really the new epicenter of the COVID pandemic in Africa, now having the highest number with over 140,000 cumulative cases and more than 2,400 fatalities. And whilst we know that South Africa was able to lock down reasonably early, providing our health system some time to contain the spread, we are now seeing a real rapid escalation. Also concerningly, this is compounded in our country with such high levels of HIV, TB, diabetes and hypertension. South Africa is currently actually relaxing its lockdown measures a little bit before we're reaching our peak, which is a little different to the trajectory of other countries. So that's going to be great to talk a little bit about in our panel. And we know that despite this time for preparation, our health system is taking strain. We've really seen our frontline providers taking the largest brunt, and definitely our poorest communities remaining vulnerable, being the most affected and faced with worsening social and economic consequences. So to get a better understanding on the impacts for children and to get some more clarity on the actual situation from the frontline in our region, I really want to welcome our panelists already introduced by Rika a little earlier. And my first question actually is going to go to Dr. Anita Parbu, who leads the COVID response at the Red Cross Children's Hospital, and just inviting you to provide us with a brief update on the current impact on children at the moment in Cape Town, and particularly if you could share some lessons with us on just the hospital's preparedness, staffing, and really what it takes to adapt to this changing landscape and the health emergency we're currently facing in our city. Thank you.
Thanks, Luann, and thanks for giving me this opportunity to just share a little bit about our experiences. So I'm a medical manager here at Red Cross War Memorial Children's Hospital in Cape Town, and we're a 272-bedded dedicated pediatric hospital. We generally see children up until the age of 13, but see many more actually up until the age of 18 if there are no other appropriate services. So when we started watching in January and early Feb, watching what's happening in Italy and the UK, we started to think about how we should plan for what was going to be happening in South Africa and Cape Town. And what we had seen is that there didn't seem to be so much impact on children, and where children did get sick, they tended to be largely asymptomatic and very few deaths. So we started to plan around how to manage it. And when we thought about what would be our role as a pediatric hospital in the Western Cape, we thought about two things mainly. The one thing is we weren't expecting kind of bed pressure from COVID pediatric patients, but we did think we would have a significant impact on staffing as with the rest of the community. And the other thing is we thought about what would be our role in terms of the provincial response and how would we be able to assist our adult facilities who also see pediatrics and maybe try and take on some of that pediatric load. And so that is what we have actually seen. We've witnessed our healthcare workers getting sick from the community, etc., and our services being impacted in that way, and also having to help out other nearby facilities and trying to assist where possible to kind of divert some of the pediatric patients across. But just in terms of managing a hospital and trying to plan for something that you're not sure about, I think some of the key learnings we've had is really about one of the key enablers is to have good communication. And we've really had to try and flatten the hierarchy. We've tried to have creative ways of communicating. In February or beginning of March, I set up daily situation report meetings where we could share with staff and address any questions immediately, but also just take questions and to discuss in more detail. And it was really important to try and reach out to all the categories of staff because this was going to affect the whole hospital. And so different staff respond to communication in different ways. WhatsApp has become a real friend of all of ours, but we have a combination of meetings on Zoom, Microsoft Teams, WhatsApps, emails, and really trying to encourage all the staff from the beginning to be flexible and adaptable. So people have really leaned into moving into different spheres of work and looking at coming out of their normal scope of practice and actually where somebody's got a passion for doing something to allow it. So for instance, at our hospital, we've got one of our pediatric cardiologists leading the testing team for our adults. And she learned from the experience of Fruitiskea Hospital up the road and has been training our surgeons, for instance, on how to do adult testing. So I think with regards to our way of managing it is to try and be as transparent as possible with the communication, but letting everyone know that the information we're giving now is what we know now. And we know that in 2 days' time, we might be telling you something different, but that's because new information is coming through so quickly. But as long as you understand that we will give it to you as fresh as we have it. And I think the other thing that we've seen in terms of our patients, we have had, just want to check quickly, we've had 80 patients in total since the beginning of the COVID. At the moment, and not all of those admitted. At the moment, we've got 7 in hospital, of which 2 in ICU. And we have had we've had 2 patient deaths. But just to be clear, both of those children had significant comorbidities and were admitted and being treated for the comorbidities and not for the COVID. So the COVID seems to be incidental. So I think it's also we can now celebrate partly because we've had 118 staff go off with COVID. We've got 86 staff back already, and the situation is evolving. We know that we're about to hit our peak, and as we've done modeling with the province initially, we realized that what we're going to have now is not such a steep peak, but more a flattened peak and for a sustained period. So I think for us, from a leadership point of view and managing, it's just the rules of clear communication and trying to just hold relationships and hold people's anxiety, because a lot of what we had to deal with is just staff being anxious and of things being so uncertain all the time. And we just share as colleagues and also trying to learn and share experiences across the province. Thanks, Luann.
Great, thank you so much. And I think just so important maybe to just acknowledge this heightened sort of level of anxiety and fear, obviously definitely experienced on the front line, but that sort of takes us a little further in terms of the levels of anxiety and obviously increasing fear we're seeing in the community at the moment. And this question is to Dr. McCullough specifically around, this increasing anxiety. As a parent myself living in Cape Town, all of our kids have been asked to go back to school. So we're seeing, lots of anxiety from parents and educators as schools are opening, especially many households, who are quite fearful given the numbers of family members with comorbidities. So Dr. McCullough, just your thoughts and lessons you can share, just providing the necessary assurances to this increasing anxiety, as well as the importance of consistent messaging and being able to balance the public health interest and the social interest for children in our region. Thanks.
Thank you very much, and thank you for having me as part of this panel. It's been a really interesting afternoon. I've really enjoyed the presentations. And firstly, the anxiety is there. It's there for the doctors, it's there for parents, it's there for students and scholars as well. And we know that a lot of teenagers have had some real issues with depression and not being able to see their buddies and real stress. And even the little guys can feel that their parents are stressed. So completely acknowledge that there's a lot of stress around. We also know that things are changing all the time. And so we try and stay on top of the research. And I was delighted to see that the presentations today really confirmed that we are not expecting the children to have very severe disease in large numbers. We can see the numbers are small. Even those who've died, we're talking 1 or 2% of the total population. What we also know is that this disease could be with us for another year or two. And so we are saying consistently, please, let's get our kids back to school. Education is vital. We can't keep kids away from education for a whole year. For a lot of kids, they feel much safer at school. Now that all the parents are going back to work, being left with either a very elderly caregiver or sometimes even completely on their own. There's a huge risk of danger being at home, getting up to mischief, but also lots of child abuse and violence that we see in our communities. So we're trying to keep our kids safe. Psychologically and mentally, we're also trying to get our kids in a better space. And for many kids, they actually get some nutrition at school. Some kids, that might be their only meal. And so we're saying we're in for the long haul. This virus is not going to go away quickly. We know that kids, as we've heard today, seem to acquire it less severely and also transmit it less severely. So when you hear that there's a school with a huge outbreak, I would actually say, look at the community. Look what's happening in the community around that school. Is this not just a reflection of what's going on in the community? And a very nice Lancet paper from May this year, we keep looking at the latest literature overseas, they spoke about this concept of non-school gatherings. So if kids aren't at school, they're going to hang around in the shopping malls, they're going to hang around in restaurants. We hear the restaurants are opening, hopefully not in casinos and gambling houses, but they're going to be hanging out in places in the community, and so they are going to be sharing and not social distancing. So we want kids back at school. We're saying do the basics right. So wear your face mask properly, keep your hands clean either by soap and water or hand sanitizer, and do social distancing. And so some of the schools have been really smart. They've actually done alternate day schooling for some of the classes if they're very big, or they've actually separated the desks as far as they can. So just think smartly. And if there is infection, then make sure that you actually don't close the entire school, but possibly just close that class and actually then try and find if there's a hotspot. So it's about thinking creatively. It's about acknowledging anxiety, but we know that kids on the whole are going to be safer back at school. They're not going to get into trouble. They're not going to be hit by stray cars. Parents are all back at work, and so there's no one to actually look after these kids except often the elderly caregivers, and those are the ones that we actually don't want to be exposed to kids sitting around with them all day long. So kids need to be educated, they need to be vaccinated, we've heard that, they need to be fed, and they need psychological input and support. So start talking about it, wear your mask, show your children how to wear their mask properly. I've even had a little guy of 3.5, 4 come into the ward this morning proudly wearing his mask because he saw that his mom is wearing her mask. So let's make it the new norm. Yes, there are going to be cases of infection, but as I said, we're concerned that it's all actually happening in the community as well. And somebody's just posted, I see on the question on the chat box, that there's a lot of sexual exploitation and bullying if they stay at home. If your child has got a very severe medical problem, speak to your pediatrician and your GP. And as the South African Pediatric Association, we say parents still need to have the right to decide to keep their kids at home if they can do distance learning, if they can keep them safe and they can keep them out of trouble. But on the whole, we know that for many children, that is not a reality. So we feel that it's best for them to go back to school.
Great. Thank you so much, Dr. McCullough. I mean, I think also importantly, just acknowledging, you know, the ranging epidemics and pandemics, and as we know also at the moment in South Africa, a raging pandemic of violence against women and children. So definitely, you know, part of that return to school needs to take that into account. I know we don't have much time, but my last question is to Prof. Rabi. I want to just ask a little bit more specifically to the actual impact he has maybe seen at Tygerberg on sort of routine care and service delivery. I mean, with this high level of fear, we've also seen a reluctance in returning to healthcare. And as Martina spoke about earlier, you know, this real disruption in our pediatric HIV services and access to ARVs. So just from your experience, your thoughts on that and any lessons how we can regain some of that confidence during this difficult time, as well as beyond in sort of building back better. Thank you.
Thanks very much for inviting me to be a panelist. And I just want to say that I'm actually working in the COVID ward at the moment, so I'm not in the pediatric HIV clinic. And that's actually part of the disruption, how we really need to reorganize staff and redeploy people and look at things very differently. And one of the most important things that we did right from the start when we realized that this was going to be a very difficult thing is, as part of the hospital plan, we had to completely declutter, for lack of a better word, all our routine services. And that is included a lot of outpatient services. And thinking through this, a lot of good reasons. You don't want patients to move around in the hospital unnecessarily. You don't want them to get onto public transport unnecessarily. And also we were aware that a hard lockdown was going to come, and how would patients come to a hospital. So one of the things that we did right from the get-go is try to give more medicine for longer periods, continue to down-refer patients to closer where they were safe, and then to try to think, like, how can we stay in touch? So one of the most important things that I've been shouting for a long time, I don't have a Facebook page, but I believe that the internet is a human right. And I think without the internet and WhatsApp, I don't know where we would have been. So one of the first things we did was we bought a phone for the clinic, got a SIM card, and we tried to get as many cell phone numbers of patients onto that phone. And with that phone, we sent people health messages, messages of encouragement, reminding them to socially distance as much as they can, and try to send some reassuring messages as well. And one of my colleagues managed that. And the next thing we did was we also basically looked at, can we facilitate engagement with healthcare staff outside of the hospital? So if you're sick or if you have a problem, you know, this is the phone that we can be contacted on. And we also, when people needed to get permits to travel, I mean, a lot of that happened in a very short time frame. So we would actually WhatsApp, oh, this patient actually does have an appointment at Tygerberg. You know, if you get caught in some roadblock or some taxi driver doesn't want to pick you up, here is, you know, some moderate modification of evidence that we actually need you. I think one of the wonderful things that we had already was a relationship with people in the community that provide healthcare, and with the MIC at UCT. So we've already been used to taking a lot of phone calls from clinicians outside, looking at pictures of skin and things like that. So we continue to provide that service, and that went on without interruption. So even before COVID-19, we tried to prevent people from needing to travel. So if you have a question on TB, you can, you know, give me a call and send me your picture, and then we can try to have a consult and advise. Sometimes you can't get away with not seeing the patient, but you know, sometimes you can. So we had already established those relationships, and those continued throughout COVID-19. We already can see that there's already been a massive reduction in TB diagnosis in South Africa, and that is going to either be because people are scared to come to health service, and because of a lot of the routine care has gone down. We're seeing already a reduction in referrals. So those patients are still there somewhere, and we need to watch carefully over time, you know, what's going to happen to TB diagnosis. I have only started in the wards 2 children on antiretrovirals in the last month and a half. Wonderful. If they don't have HIV, I'm glad, but I think some of these children may actually be not coming back to clinic, not getting their HIV test results. We did see a a slightly longer turnaround time for some of our tests, because certainly the virology lab was overwhelmed. And they actually did an amazing job redeploying staff and looking at volunteers to help them, because just logging all of these specimens that needed to come through, you know, into the system. So even if the machine was available for viral loads and HIV tests, you know, that, you know, staff had to do that. And so, I mean, they did an amazing job just getting around and redistributing that. For pharmacy, as I said, we gave longer prescriptions. We work with the pharmacists to try to get children not to move through the hospital, and pre-packaging, which we've done before, but we've just taken that, you know, increased that. And we've actually, for 1 or 2 of our children on third line, and I know that some of the other specialty clinics also use the same, we even Ubered the medication to the patients for when we really couldn't manage. That's quite a logistic endeavor, but it can be done. At the moment, I think we're worrying, how much money do people have left? Can they still buy data? Do they still have access? And basically looking at that. When we're looking at, you know, just general sort of interesting comments, we need to watch the impact of COVID-19 on our TB and HIV patients, and especially our TB patients. And interestingly, we've got a few patients who've been non-adherent who've come back because they're worried, and they've heard that if you have HIV, you might be at higher risk. So 1 or 2 of our straying adolescents have actually turned up on their own, asking for antiretrovirals, which is really smart and, you know, wonderful. 1 or 2 of the other things that we've had to do is take risk. I think where before we would have wanted somebody, you know, who's been unwell to come back to the clinic for a checkup, we try to avoid them actually engaging with the healthcare system, you know, if we can at all avoid it. So, you know, we need to see in the future, did that risk actually translate into something better for the patient? And I think sometimes we are cautious, and sometimes we can take a little bit more risk. And, you know, when you're thinking, should I start you on AZT, 3-T-Nevirapine when you're like 25 days, or can I just go for a normal regimen? If people are phoning me, maybe we can take that risk safely. And when people call you, you can advise them, you know, looking at that more safely. And I think one of the other things, just sort of off the top of my head, that I forgot to mention in the beginning, is for all the people looking after chronically ill patients, is we really worked very hard this year to try to get the flu vaccine into our patients. And I'm not sure that we were very successful, but because I think as the cycle of returning to clinic actually became disrupted during the time frame that we had to start the flu vaccine at the clinic. So I think that also affected our patients' access to non-routine vaccines, but also we need to really be careful now with catching up on routine vaccines. And I know that there is also a provincial task team looking at that. Yeah, so I think in general, we're still waiting to see what's going to happen. We're trying to keep an eye for, you know, patients that we down referred, making sure that they arrived, and also just keeping in touch with patients through WhatsApp, and taking a lot of phone calls of patients. But we need to watch the space carefully. I think whether COVID-19, as we can see, has already affected TB diagnosis, whether it will affect the PMT-CT program, and how many, if any, increases in transmission we'll see as patients are reluctant to attend healthcare and come into definitely Tygerberg, which has been named the COVID hospital according to the community. I come here to be safe, but they stay away at times because they are scared. And I think they are scared with reason, because they know they have to travel, they have to come through the doors. And then I think one of the most difficult things is the way that staff attitude is you know, it's like a BLS situation where before you want to help, now you first have to ask, is the staff safe? And so we also had to look at how we make sure that staff are safe in all of the clinics. And part of that is reducing the patient flow through the clinic. And, you know, if you have a resuscitation, the first question isn't, you know, where's the bag and mask? It's, is the staff, are the staff safe? And I think that's a whole different way of thinking that we've had to adjust to as well.
Great, thank you so much. I mean, I think importantly also, you know, just for those who are still on the call, and we're going to go on for a few more minutes, hoping that those who can stay online will just stay with us for a little longer. But I mean, of course, even in the context of South Africa, like across our region, you actually are all from hospitals that, you know, compared to many other hospitals in our country, as well as in terms of primary healthcare settings, you know, you're probably quite better resourced. And we know that in certain provinces right now in South Africa, the Eastern Cape, for example, you know, our health system is really, really under strain. And when you're talking about sort of motivation of staff and leadership, you know, we're seeing really, really sad examples of, you know, literally staff too scared to go to work, striking. We've seen a whole lot of samples literally all just, you know, thrown out of a vehicle on the side of the road today. So, I mean, these are going to be not essentially presenting in the same ways, in the same context, because of our country and our region is so different. But maybe just opening it to the other panelists, if there's maybe something that you wanted to add on, or sort of one last key message before I say thank you to you all.
I can just comment, I think the fear in the staff in the Western Cape is exactly the same as the fear of the staff anywhere else in the country, and for that matter, anywhere else in the world. And I think doctors tend to take care of ourselves a little bit better because we simply have more money. And we're not dealing with cleaners and with, you know, people who don't have a lot of money. And that's a real issue. And I think this is where, you know, the management and the leadership is really, really important, to listen to staff. You know, personally, I'm sure Dr. Pabo and Dr. McCullough the same. We invest a lot of time, an amazing amount of time in reassuring staff as much as we can, while acknowledging that they are doing a dangerous job. And I mean, we mustn't underestimate how many of our staff have HIV, how many of them are suffering from obesity, hypertension, diabetes. That's not me, but I'm on the old side, so that's also coming. So I think we really have to invest in that. And I think here you have to show leadership. You know, I've been cleaning rooms in my ward because there is no cleaner to clean rooms. And cleaning room and making sure that the area is clean is crucial for safe care of patients and for safety of staff. So I think it's something that we have to grapple with. It comes more into play in places where you know that there's clear mismanagement and funds have been diverted inappropriately. But this fear it's a real and it's tangible. And when you see a nurse going into a room trembling, but still going in because she's looking after a COVID patient the best she can, you know, that is when you develop real respect for people. And I think I just thank people every day for coming to work. And we've lost staff members in our department. People have ended up in ICU. So we know that they are making a tremendous effort to care for patients.
I can just extend that. And I think it's often about telling the same message again and again. It's about transparency. It's about saying, how are you guys feeling? Are you still feeling scared about this? Remember to wear your masks. It's really important. So it's about bringing the messages across. And, you know, we've all done training and teaching at all levels. And often you need to go back to the same group and say the next week, how are you guys feeling? Are you okay? And then when we have lost somebody, it's about taking time out and maybe having a little candle lighting ceremony, just to acknowledge that that person was really special and to acknowledge the fear. So I think we're all on the same page. And This is really, as Anita was saying earlier, this is not about any hierarchy. This is everybody on the same level and having transparency and actually spreading information on a daily basis. I think the places where staff have run away because they're terrified, it's because no one's actually sat down with them and said, let's talk about what makes you scared. And what makes you scared this week may be different to next week. So, and the same goes for teachers, the same goes for parents, and the same goes for the students, not just the teenagers, but the little guys as well. So there are resources out there. There's some really nice books that I've seen explaining about COVID to even the youngest kids. So I think it's about sharing education, and things change on a day-to-day basis. So I really am delighted that you've put this webinar together. I think it's been fantastic. And just to everybody, keep up your good work wherever you're working.
Thank you so much. Anita, do you want to say a final word?
I'll echo what Prof. Rabi and Prof. McCulloch have said. And I think the thing that we've tried to do is just to keep your ear to the ground, to try and be there to listen to anyone. So, you know, do away with this thing of just that everybody, the professors and the heads of departments have the expertise, and just listen to everyone, because the cleaner might know exactly where things are not going well, or the porters, because they're moving patients around between different departments, and they know exactly where everyone's doing what they're supposed to and where people are not. And the other saga that we've had to deal with, I call it the tea rooms and travel buddies saga. It's just, you know, those are the things. So you'll find in terms of human behavior, actually in our hospital, the one designated COVID ward is where we've had the lowest number of staff becoming COVID positive, because they are so careful of what they're doing and what they're wearing and how they're interacting with the patients. In other places, you'll find that they're doing the correct PPE, they're doing the social distancing, and as soon as they go into a tea room, take the mask off and are in a different social setting, they suddenly forget and they become human, and they're standing next to their buddies, showing WhatsApp photos of their children, etc. And it just, as that Fleck advert used to say, all resistance crumbles. So it's just trying to make people mindful of the formal settings as well as the informal settings, because that's often where we found that things have fallen down. But I think just what everyone is saying is listen to the staff, listen to everybody, and where you hear things coming up, try and pick up those issues and see and where you need to address it, and pay attention to those little things, because often the little things lead you to bigger outcomes in terms of managing the COVID. So thank you very much. Thanks.
Great. Thank you. Thank you so much to all of our panelists. Definitely a good dose of reality. And really, you know, a huge reminder of the immense sacrifices all of you and all of those first responders and health providers are making every day. So just a huge thank you. And back to you, Rika. Thank you so much.
Thank you very much, Luann, and thanks to all four of you. It was really insightful and eye-opening. I'll hand over to my colleague Shafiq Isaji, who's our senior HIV advisor, just to close out the webinar. Over to you, Shafiq.
Thank you, Rika. We are way over time, but it's a testament to the interest and enthusiasm that everybody has for this topic, that we still have 150 people on the webinar, even almost 15 minutes in. Really, we can't thank you enough for the excellent presentations, the tremendous perspectives from the field. Thank you to Anita, Helena, and Mignon for your amazing reflections, incredibly valuable to us as we think about how we should work as a global community to support safe reopening, reintegration, you know, approaching a normalization of our schools, of our health services, and of our societies. So hopefully we will continue with this series, and we look forward to seeing you on the next webinar. In the meantime, please look at the links that are now being shared on the screen. If you have additional questions arising, we have a web discussion space that you're welcome to submit questions to. And a reminder that the presentation, as well as the recording of this webinar, will be available from tomorrow on our website, Children and AIDS, on the Learning Collaborative. So thank you again. Have a very good day to the rest of you, and stay safe and secure.